Okay, for the next presentation, we're splitting it between two of the newer physicians that are on staff with us at Sinai. First is Dr. Oleg Gligich. It's hard to believe he's been here almost 2 years, and it is rumored that he was the one who brought COVID because he started in 2019. And the other one is Dr. Raja, who is probably just finishing her 90-day probation. And we decided we'd keep her. Okay, she came to us via Seattle and Nashville. So Dr. Oleg is going to present first. They're actually going to do some cases that we're going to be able to relate back to Dr. Kuzner's talk.
Usually, you know, okay, they can't stand anywhere. All right. Well, wow. What can I say? Going after Dr. Kuzner is a very tough act to follow. So let's give Dr. Kuzner one more round of applause. What a boss. What a boss. Wow. I do want to tell everybody I am super excited to be here, and I want to thank Karen for inviting me here because, I mean, it's amazing, and I finally had a chance to actually talk to some of my colleagues and see what their faces look like without masks. It's nice. I like it. But without further ado, let's do some cases. So our first case is of a patient MV, and everybody hear me well, right? Yeah, great. All right, so she is a 59-year-old female with a past medical history of asthma, high blood pressure, and hyperlipidemia. She comes into the emergency room with worsening shortness of breath for about 3 months, and now she's having dyspnea on exertion. She has a 20-pound weight loss and 3 months of severe fatigue. She's a never smoker. She works as a school teacher and unfortunately has not been able to teach our kids for a few weeks now. On exam, she's weak, frail, she's on 6 liters of oxygen, she has bilateral crackles, decreased breath sounds, she's not looking so good. There's a chest x-ray that's done in the emergency room, and that shows extensive bilateral pulmonary consolidations with a left pleural effusion. She has a CAT scan done, and you don't need to be a radiologist to see that there's something in the lungs. The read says bilateral diffuse ground glass opacities with mass-like consolidations throughout both lung fields. And through year 2000 and 2001, when you see that, the first thing most physicians think of is COVID. Good. Yeah, so she was COVID negative ×2. But instead she undergoes transbronchial biopsies of both the right lower lung fields and the left lower lung fields, and pathology is consistent, unfortunately, with an adenocarcinoma with lipidic and micropapillary features. She then has a PET scan, which again, you don't need to be a radiologist to appreciate that the impression said bilateral lungs are on fire. Just kidding. She has a left lower lung field with an SUV of 25 and bilateral infiltrates, which are very, very, very hot. So following HPI, she is staged as an M1A adenocarcinoma of the lung, and next gene sequencing with Caris and Garden 360 are sent. She unfortunately has a clinical deterioration. She continues getting worse. Her large tumor burden is what forces us to give her 1 cycle of carboplatin and pemetrexate. And as you heard from Dr. Kuzner's talk, immunotherapy was held in order to, God forbid, if she did end up having an EGFR mutation, we wouldn't increase her toxicity if we were going to end up giving her Tagrisso. It's pretty standard clinical practice. She returns with her daughter on a 10-day toxicity check and actually is doing a little bit better. Some of her symptoms improved. Unfortunately, she's still oxygen dependent, still has dyspnea and exertion, and a pretty poor appetite. Her next gene sequencing that same day comes back, and she has a B-RAF V600E, which is confirmed on Caris, with a PD-L1 expression of only 1 to 2%. The FDA-approved targets here, as you've heard from Dr. Kuzner's talk, are dabrafenib and trametinib. She started on dabrafenib, Tafinlar 150 milligrams Q12, and trametinib, Mekinist, at 2 milligrams daily. She then comes back 2 weeks later, still accompanied by her daughter. However, her appetite has significantly improved. Her weight is up, energy is better. She's on oxygen, but now only 2 liters. She's now starting to experience some low-grade fevers, which are a pretty common class effect of these medications, and has some lower extremity swelling. She's advised to take some Tylenol for her fevers and to come back 4 weeks later, at which time she now comes in alone. She's not on oxygen, energy levels are good, she's eating well, appetite is up. Her fevers are well controlled on Tylenol PRN, lower extremity swelling has since resolved. Her repeat PET scan now shows no fire in the lungs with a little bit of SUV on the left lower quad. I would say an SUV of about 4, maybe 5 tops. If you don't remember what her PET scan looked like before, that's what it looks like. So, well, what's BRAF? BRAF is a downstream signaling mediator of the Kirsten rat sarcoma viral oncogene homolog, KRAS. And as you can appreciate in this cartoon, if BRAF is constitutively activated, it will fire downstream into MEK and ERK, and in turn affect transcription, cell division, and differentiation. And as you heard from Dr. Kuznier's talk, this is a very basic, limited expression of what actually happens in the cell. BRAF has more than 30 different mutations and has been identified in a variety of different cancers. It's up to 100% in hair cell, even though we don't target it. It's in 50% of melanomas, 3% in colorectal cancers, and 1 to 3% of lung cancers. The most common one is what we have here, which is the V600E, which appears to have a better prognosis than non-V600E mutations. Interestingly enough, both of them have a better response to immunotherapy than other oncogenic drivers, even though, as again, you heard from Dr. Kuznier's talk, immunotherapy is not the way to go when you have targets. You want to target the target. BRAF classifications are categorized based on what their functional impact is on the MAP kinase pathway. There's 3 different classes. Class 1 being the V600E mutation and constitutively activates the RAS kinase pathway. It's more likely to be in light or never smokers and has a much better median overall survival than the other 2 classes, most likely because it doesn't have CNS mets. Class 2 and 3 are the V non-600E mutations that produce an active RAF kinase or a non-RAF kinase, and the median overall survival is much worse, and this happens in patients that smoke. So a little bit about the BRAFINIB and tremectinib, which isn't new for this group because we know we use this in melanoma. But the FDA label here for non-small cell lung cancers is for patients who have a V600E mutation who've progressed on chemotherapy. However, as you'll see in the following slide, the type of response rates we see here, most clinicians end up using this in the frontline setting. The FDA approval is based on a phase 2, where 57 patients with previously treated and 36 patients with previously untreated non-small cell lung cancer patients who had BRAF mutations and have received at least 1 to 3 prior lines of therapies. The combination was associated here with an overall response rate of 63 to 64%, with a disease control rate of up to 80%, and a median PFS of 9.7 to 10.9 months, depending on patients were treated or not treated. The most recent publication last month was a 5-year follow-up of this study, which confirmed the response rate of 80%, the median PFS of 10.8 months, and a median OS of 18 months. There was 34 patients that were alive at 4 years. There was 22 patients alive at 5 years. And as people know that take care of stage 4 lung cancer patients, this is pretty impressive with a pretty durable response rate. So without further ado, we'll move on to case number 2, which is CW, who's a 50-year-old female with a past medical history of uterine fibroids who presents to a PCP with severe fatigue, 15-pound weight loss, hemoptysis for about a month, and she's very concerned. She has dyspnea on exertion, however, she's able to do some of her usual daily tasks as she works as a nurse and does not want to leave work. She's a never smoker, and on physical exam, she has bilateral wheezing. Her CAT scan, again, you don't need to be a radiologist to determine that she has multiple cannonball lesions in bilateral lungs. She has a CT of the abdomen and pelvis, which shows a 6-centimeter left hilum and multiple para-aortic and retroperitoneal lymph nodes, measuring 2 centimeters. The radiologist was nice enough to put measurements here for us. She undergoes a CT-guided biopsy of the left lower lobe, which is unfortunately consistent with metastatic urothelial carcinoma. Again, NGS was sent out with both Caris and Guardant 360, and she is found to have an FGFR3, which is confirmed on Caris. And again, there's an associated FDA-approved medication here, ERDAFITINIB. She unfortunately refuses chemotherapy, but as you see further in the presentation, that was probably a better choice. She also refused the clinical trial and hence was started on ERDAFITINIB, BALVERSA 8 milligrams daily. She was advised to restrict any phosphate intake. She monitored for changes in vision, and after about 14 to 21 days, as long as her phosphate levels were under 5.5 milligrams per deciliter, she could increase her dose to 9 milligrams once daily. On follow-up, her hemoptysis has since resolved, her appetite is back, she's putting on some weight, and a repeat CT chest 3 months later doesn't show a complete slam dunk, but pretty good as compared to what it was before, as you guys can appreciate. So let's talk about the FGFR receptor a little bit, which binds members of the fibroblast growth factor family of proteins, which is one of the largest families of growth factor ligands, consisting of 22 different members. The FGFR receptor comprises of an extracellular ligand, a single transmembrane helix, and an intracellular tyrosine kinase domain, which fires down multiple pathways eventually to promote survival, growth, differentiation, and migration. There's at least 5 different subtypes of the FGFR receptor, including FGFR 1 through 4, as well as FGFR-L-1. What's important to point out here is that FGFR1 amplifications are seen in squamous cell non-small cell lung cancers, but unfortunately targeting these mutations have only promoted about 5 to 10% response rate. FGFR3 mutations have been found, like in our cancer patient with bladder cancer, in 50 to 60% of non-small cell and 10 to 15% of muscle invasive. And obviously with Dr. Kuznir being here, we want to make sure that we mention the FGFR2 receptor, which is frequently found in cholangiocarcinomas, and obviously there's an approved medication for that as well, pemigatinib. And the drug reps didn't tell me to say that. Subtypes of muscle invasive bladder cancers. So mutations and fusions of such FGFR2 and 3s are common in patients that have urothelial cancers, in particularly the luminal subtype, which is about 20%. 40% of upper urothelial tracts also have this mutation. It's important because the luminal subtype has been associated with a much poorer response to immune checkpoint inhibitors, and it has a lower PD-L1 expression. Hence, FGFR inhibitors here are very interesting, as this is probably the way to go, as you've both seen in our patient and you'll see in the following subtypes. Last year, there was a molecular NGS analysis of all the bladder tumors that were done in Europe. It was published in a European journal, because obviously they weren't publishing anything else. And what you're able to appreciate here is that there's 6 distinct subtypes for muscle invasive bladder cancer, with luminal papillary and the basal squamous being the predominant subtypes, being about 55%. What's important to note here is that they each have distinct oncogenic mechanisms and mutations, with the luminal papillary having an FGFR3 mutation, the luminal unstable having an ERB2 or HER2, and the basal squamous having an EGFR. Unfortunately, targeting these subsequent mutations have not led to response rates. What else is important to point out here is that this is not only prognostic based on overall survival being 4 years for laminal papillaries and neuroendocrines around 1 year, but it's also predictive because we know in the basal squamous subtypes there's a very enriched CD4 count and CD8 count in the cellular matrix. Hence, these are more likely to respond to immunotherapy, whereas our FGFR mutator luminal subtypes are less likely to respond to immunotherapy. So let's talk about BALVERSA a little bit, or ERDAFITINIB, which is a pan-FGFR kinase inhibitor, which inhibits multiple targets, including FGFR1 through 4, RET, CSF1R, PDGFR alpha beta, FLIP4, KIT, and VEGFR2. The FDA granted approval for ERDAFITINIB for patients with locally advanced or metastatic urothelial carcinomas with FGFR2 and 3 genetic alterations that have progressed during the following platinum-containing chemotherapy, including within 12 months of neoadjuvant or adjuvant chemo. It's a mouthful, but bottom line, it's based on this BCL-2001 trial, which was an open-label, non-randomized phase 2. It included 99 patients, of which 43% had received at least 2 prior lines of therapy. To dive a little bit deeper into the trial, the response rates here were 40%, and out of which 60% of these patients had had prior immunotherapy. Out of those 60 patients, only 5 had responses to immunotherapy. The median duration of response here was 5.6 months. The median PFS was about 5.5 months, and the median OS was 14 months. Toxicities include grade 3s, which are hyponatremia at 11%, stomatitis at 10%, asthenia at 7%. The most common adverse events are hyperphosphatemia, which is a known class effect of FGFR inhibitors. It's also important to note that there's multiple ocular toxicities that can happen, and you need that those ocular toxicities happen within the first 50 days, so it's important that these patients see ophthalmology and get evaluations almost weekly for the first 4 weeks. They also get stomatitis at 58%, diarrhea at 51%, and dry mouth at 46%. So super easy to take, very well tolerated drug, yeah. But, you know, what else do we have? And what do we have? So, well, before 2016, medical oncologists were arguing between giving dose-dense MVAC or cis-GEM, and which one was more toxic and which one had better overall survivals. They're both pretty crappy regimens. So, but in the past 5 years, we've had an explosion of immunotherapies. We've had multiple targets. And before 2016, our median overall survival was 13 months. The most recent immunotherapy based on the Javelin now has 22 months, which was in September 2020, which was followed by enfortumab with a median overall survival of 13 months at second line. And last but not least, the most recent approval of sacituzumab in third line with a 30% response rate. So we're doing okay. I think we're doing okay. So where's the future? And, you know, like Dr. Kuznier said, it's not going to be a one-size-fits-all type of store. I think in the near future, we're going to have personalized medicine with next-gene sequencing. We're going to detect the right appropriate biomarkers for the right patients at the right time, and we're going to individualize treatments that are algorithmic based for our patients in front of us. And that's all I got. Thank you, guys.